Thank you. All right, change of pace. I'll stand up here now. We're going to talk a bit about orthopedic trauma now and how we go about managing these cases. I'm going to try and get through this so we've got plenty of question time because I'm really encouraged by the engagement and the number of questions that we have. So I just wanted to show you, this is the ICU in my hospital here. Similar to Ellie's, we've got a dedicated ICU, and this is one of Ellie's colleagues, who's one of my business partners here. I want you to note again the amazing work the ICU team do. You can see these numbers of infusions all running constantly. This is not something that I would ever be able to do, but our nursing team are incredible and work with vets like Ellie and Louie to really give our animals the best chance after severe trauma. Because trauma is certainly something we see very commonly. This would make up the majority of my surgical caseload. We see road traffic accidents. I don't know if this is something you see high-rise falls in cats, but in Sydney we would see a couple of a week. People constantly think cats don't fall off balconies, but they do. And then dog bites, and we spoke about them yesterday. Now the thing about polytrauma is it's not just multiple systems that are affected, but it's also multiple anatomical regions. And so we talked about the challenges of missed injury, and I know I keep harping on about this, but this is so important that we're constantly re-evaluating our patients to make sure we understand the full extent of the trauma and the injury. So, Ellie, this is like repetition now. Ellie is going to, she spoke to you yesterday about survival hour, the importance of the primary survey. She talked to you about the secondary survey and how important this was. I'm going to add something extra into this now. And I'm going to add in an additional step. I think the primary and secondary survey give us an excellent framework, but even with the primary and secondary survey, we know that sometimes up to 50% of patients can have a delayed diagnosis. These are human patients, and these are patients that can tell the doctors, my hip hurts. They come in for a hand injury, but they've got another injury concurrently. And so this often happens, and there are scientific studies that have looked into the problem of proportionalization. You focus on the life-threatening injuries, as you should, with a lot more of your time, meaning that the smaller injuries are the ones that can be missed. And so something that I started implementing in my practice probably 5 years ago was something we call the tertiary survey. So we have a completely different vet come into the case about 24 hours after presentation. It means that the emergency vet who's focused on those life-threatening injuries doesn't have to identify the full extent of the injuries. So a different veterinarian comes in 24 hours later after the dust has settled and re-evaluates that patient as if it was a new hospital admission. And this has been shown as one strategy to reduce missed injury rates. And one of the things that you do as the new clinician coming into a case is we can look at this pattern of injury that we see very commonly. Now I'm going to use high-rise syndrome as an example. So this has been classified as falls of over 2 meters. When we studied large number of cases, and when you look at the numbers here in these studies, many of them are well over 100 cases. This is common in countries all around the world. We can see consistency in the kind of injuries that occur. And this helps you focus your attention onto those key areas of potential trauma. And so, particularly with high-rise, we talk about limb fractures. We're going to talk about open fractures because it's not uncommon with high-rise cats. Orofacial trauma, really common. We believe the cats hit the ground with their limbs first, then their head goes down and hits the ground. And so again, facial and head trauma is very commonly. And then chest injury. So it goes feet, face, and then the chest. So this produces a very consistent pattern of injury. So often these animals come in, often with major limb trauma. Sometimes one limb is fractured, sometimes 2, sometimes 3. Occasionally we see animals that have 4 fractured limbs. It's very easy to focus our attention on that and to forget about the other injuries. But what I look for in these cats in terms of orofacial trauma is I look for occlusion. If the mouth doesn't close perfectly, something has gone wrong. Now in this cat, the initial emergency veterinarian could feel instability in the mandible. On this CT scan, you can see what they've done to address that. They've wired the mandible. That's appropriate. But in our tertiary survey, when we came on the next morning to look at this cat, we can see the occlusion is not perfect. And this tells us that there is likely other injuries. And so we mentioned again how we can use advanced imaging like a CT scan to more fully assess areas with complex anatomy where the bones all overlap each other. And this is that same cat here. We can see we've got a slab fracture at the upper canine tooth. We've got skull fractures here at the base of the skull and even mandibular fractures. And so with advanced imaging, we're understanding the degree of trauma in these patients with limb injuries is often far more extensive than what we believe. So if you see a high-rise cat, you would always check that hard palate. And what you may just see is a very faint line along here. It may seem insignificant, but it can cause major problems because now this is a connection between the oral and the nasal cavity. Palpate that mandibular symphysis. Commonly these are injured, and check all the teeth because initially that may not cause a problem, but again, if an owner spends a lot of money fixing the obvious and then you have to do additional procedures, this can mean the owners can get upset if you keep finding new things. And so I like to try and find all the injuries and tell the owners, I may not fix that right away, but we will need to come back and fix that and prepare them financially for those additional steps. When it comes to the hard palate, the other thing that you look for is epistaxis. If a cat has nasal bleeding, it's highly likely that it's sustained head trauma, and that will cue you, once again, to look at that soft palate, or that hard palate, sorry. And in this case here, we see a very clear cleft. Now, in the simplest of cases, these can just be sutured. So I'll use non-absorbable suture material, and I generally don't debride because I've got now healthy wound edges. It's just opened up. So if I can't see into the nasal cavity, I just suture them. It's not separated. If we've got a much larger cleft, and here you can actually see that gap there, that black gap. If you try and suture this, this will likely fail. And the reason is often you have the hard palate that's separated. Now, if on a CT scan you see that, you can actually reduce that by putting a little K-wire dorsal to the hard palate through the nasal cavity and a little figure-of-8 wire to bring those together. In this case here, if it's minor, then you can create a little advancement flap. So you make an incision on the inside dental arcade here, elevate a flap to cover over that deficit. And that area of ulceration that we see here, just here, this area has underlying bone and will heal very quickly. Ellie talked about the importance of watching our patients walk, because if you have a single limb injury, your patient will be ambulatory. I make them walk almost every day so I can assess to see if the injuries I've treated has resolved the problem. So here's a high-rise cat. You can see orofacial trauma, fracture in the hard palate. Here we're going to watch this cat walk. It's had a fracture repair done the previous day. And what I'm looking for is that we're weight-bearing nicely in all remaining limbs. And I haven't missed a fracture occurring at another site. So limb injuries are very common. They're often the first point of contact. Check if they're ambulatory. But sometimes when you're that vet coming in 24 hours after to do the tertiary survey, your patient might look like this. It's got a urinary catheter in, it's got bandages, it's got an IV line. It's really hard to assess them when they've got all of those. And so Ellie, I think yesterday, spoke to you about the fact that early on in the process, before you put in those lines, sometimes nice to see how well they're walking. Because again, multiple fractures are common. These are the easy ones to pick. So mid-antebrachial fractures, this is the left and right limb of one cat. Here we can see we've repaired these. Yep, and in cats I repair both radius and ulna because the ulna has a greater role to play in the cat than it does the dog. And this is the cat, well, I'll show you this one here. The one with the bandages is 2 days after surgery and the other one is 2 weeks after surgery. So again, we're always watching them walk to see how well they're ambulating around. But there are some fractures which are harder to pick. So here we see Salter-Harris fractures. So these two here, they're both fractured, but they're growth plate, non-displaced, but may require stabilization. And we also see ligamentous injuries, and we spoke a bit about those. So we spoke about this in terms of the importance of palpation and taking stressed radiographs. So, high-rise syndrome, we're looking for orofacial trauma, limb injury, and thoracic trauma. So we're going to look at thoracic radiographs as well. Okay. Enough of high-rise. I want to talk now about how you might manage the patient that comes in with a palpable fracture. So, any patient that presents to you with a limb fracture has likely undergone major trauma. To break a bone takes quite significant force. So you want to stabilize the patient. Again, we get Ellie to come in and help us with that. Address all those life-threatening injuries. I like to provide pain relief very early on in the process. But whilst I give them pain relief, if they're otherwise stable, here is an opportunity to potentially take some radiographs, so we can do it all in one go, take the radiographs and potentially then also immobilize the limb. Because we know much of the pain with a fracture comes from the constant movement. And so if you are going to give them a strong analgesic like an opiate, often that animal will become much easier to handle. This is an opportunity where you can take your radiographs and immobilize the limb. And immobilizing the limb will not just help with pain, it will prevent further tissue injury. So this is little Riley here. You can see Riley sustained radius ulnar fracture. These are very common in the Italian Greyhound, but we took these quite soon after presentation once we'd given adequate pain relief. We then would go on to immobilize that. Now I'm going to show you a little sequence of events to show you how I actually apply those bandages. But my temporary immobilization is either a Robert Jones bandage or a fiberglass splint. And so I'm going to show you the Robert Jones bandage first. I generally use stirrups, so this is tape placed medially and laterally to stop that bandage sliding down. For a true Robert Jones bandage, you want a roll of cotton wool. The ability of a Robert Jones bandage to provide immobility is its size. So don't use the soft band that's very small. You'll go through lots and lots. You'll need a buyer's group if you're going to use that very thin casting material, because you'll use rolls and rolls of it. So cotton wool works nicely. Wrap that around the limb. It needs to be big. So, we're now talking about several, 5 centimeters of cotton wool. We're going to then place our bandage to tighten that. You can do multiple layers if you're not happy with that first layer. And then again, the tertiary layers on top of that. So the secret with the Robert Jones bandage is going to be its size. So they're quite bulky. So I prefer actually to place a modified Robert Jones, which is a thinner version, and then a fiberglass splint, which provides better immobilization. So I'm going to show you a little video here and how that works. I'm going to apologize in advance. This is on the weekend. I'm wearing shorts, but I came into the hospital, this animal presented, and I said, let's just get this done now. So I apologize in advance. I'll play the video. So there's our Robert Jones, a modified Robert Jones here. I get fiberglass material here. I measure the length here. And I create about a 6 to 8 layer thickness, depending on the size of the patient. Wear gloves because this is very sticky. It's got lots of resin here. You can see the patient here is anesthetized while we're doing this. I haven't edited this, so you're seeing this in real time. This is how long it takes. Don't put that down, because anywhere you put it down will become sticky. Don't put it on your radiology table, because it will leave a mark that will come up on all radiographs. So, see how we don't put it on the table, put it in the packet so we don't get in trouble. Action, here we go. Off we go to the sink. Don't use hot water, just normal room temperature water. Soak it all. Soak it really well. Okay. And then we're going to wring it out, nice and dry. Like this. Make sure it's nice and dry. Then we're going to come over to the patient here, and there are a few little tricks when you put this on the limb. So here for an antebrachial fracture, this is a border collie with a radius ulnar fracture. I place it on the back. Don't hold it tight, because you'll leave your fingerprints there. So we're just constantly moving our hands so that it doesn't indent. We want it nice and smooth. So the way I think about this is my initial Robert Jones, the modified Robert Jones, takes complex anatomy and makes it simpler. It makes it a smoother tube. So then when I put my splint on, then again it's held tight. The splint is only there temporarily. It's not my definitive fixation, but it's just simply there temporarily overnight until this patient gets to surgery the following day. If it's the hind limb, it's a little bit different. So I'll take you through here. This is what we need. Again, equipment. This is how I would do the hind limb. I like to pad between the lateral digits because one of the risks is that that nail of 2 and 5 can erode into the adjacent digit. I don't put padding in the centre, but just the 2 lateral digits. Stirrups, as we said before, nothing different here. Now we're using casting material. This is a modified Robert Jones initially. And here are the areas that I'm worried about. These are the common areas where we get rub points. So we mentioned this one right here. This is the nail eroding here into the adjacent digit. I'm worried about the widest, most lateral and medial point. So this is the metatarso-phalangeal joint. I'm worried about the calcaneus. I'm worried about the flexor surface of the hock. And I'm also worried about the flexor surface of the stifle. Because if all your bandage ends right here and the animal flexes up, they can get pressure sores right behind the knee. So they're the areas that I'm really watching for. So when I use my conforming bandage, it's about a 50% overlap here. And then now again, I've shown you this, but if we're going to put it on as a full cast, because this is a full cast that will apply, then rather than creating that slab, now we're going to soak the whole thing. If you do it in boiling water, you have about 3 seconds before it sets like rock. You only do that once to remember that. So you're just using the temperature of room temperature water. And now we're going to roll this on slowly, about a 50% overlap here. You need an assistant. You need to wear gloves for this. It's very sticky. So it's gentle and smooth. I don't want any irregularities that are going to cause pressure in this limb. Once I've got that full cast on, then I bivalve it. And you can either do that mediolaterally or craniocaudally. It doesn't really matter. But then it's 2 halves. So if I want just a splint, I'm just going to take half of that. If I want a full cast, I leave that in place. So once you've bivalved it, you can use tape to hold it back together as a full cast, or you can just use half. The alternative for that is you can do a slab, just as we did with a forelimb, on the lateral aspect. It generally goes on the lateral side and then curves underneath the foot. And that's a really nice way of providing immobility around the tarsus. If you want to go to the stifle above, it's a little harder. I should say, though, we're only talking now about fractures below the stifle or below the elbow. If it's femoral or humeral, there's nothing you can do to stabilise those. Those patients are given analgesia and kept cage confined. You will cause more damage if you try to mobilise them with a bandage because the weight of the bandage will cause the patient more pain. Those cases just get to surgery, and that's the best way to provide pain relief. And then tertiary layers, you can add anything you want and make them as pretty as possible. When I worked at the university, we had students with too much time on their hands, and they would create these amazing bandages. Lovely. And once you've temporarily immobilised it, now we've got our radiographs, we're going to plan to go to surgery. And so many of you know this is one of my true passions here is fixing broken bones and working here with Ken Johnson, my mentor. And so if we want to look at what's our surgical plan, it would be amiss not to mention the AO Foundation. Could I have a show of hands? Who's heard of the AO Foundation? Fantastic. Excellent. Well, the AO Foundation is a not-for-profit organisation, so I don't feel bad about mentioning it here. But for those of you who are not acquainted with this foundation, I'm going to ask you now to close your eyes and then open them again. And I'm going to transport you from Chandigarh in India to the Swiss Alps in the 1950s. So this was an amazing time where everyone was happy. The war was over. People started finding recreational pursuits. One of the most popular in Switzerland at the time was downhill skiing. Now, those of you who've been downhill skiing know it's possibly one of the most dangerous sports you can do. And what goes with downhill skiing is long bone fractures. And in the 1950s, not that long ago, the mainstay for treatment for long bone fractures was traction. You would spend 8 to 10 weeks in a bed with that limb immobilized. There were huge numbers of consequences of having your limb immobilized. The function was often poor and the outcomes were bad. And so what happened in the 1950s, there were surgeons, Swiss surgeons, that got together and said, we can do better than this. We're not really working together as a group. We're all fragmented. And so these 5 founding fathers, they all met in this hotel in Bern in Switzerland, and they formed the AO Foundation. Now, we abbreviate it to AO because AO stands for the Arbeitsgemeinschaft für Osteosynthese Fragen. This is not an easy thing to say. English version, Association for the Study of Internal Fixation. And you'll see this referenced often as AO, ASIF. It's become a standard. Because what these 5 founders recognised is to improve orthopaedics around the world, we needed 4 key things. We needed to document everything that was happening. We needed new implants. We needed research. We needed innovation. We needed to research how bones healed so we could learn how better to support the body. And finally, we needed to teach, and we needed to spread that word. And so, the following year, they developed the AO Research Institute in this small building here. The following year, the first AO teaching course was held in Switzerland. You could see a global audience already, so not just Swiss participants. And what I find fascinating is to this very day, the AO Research Institute still exists, and this is it in Davos now in Switzerland. If you get a chance to visit, it's like a pilgrimage for any orthopaedic surgeon. And the courses still run every year in Davos at the same time. The next course is being held in 2 weeks' time, Toy Breed Fractures, chaired by Lucas Beyer, one of my colleagues from Australia, and Stefan Scharvogel in Davos in the Swiss Alps. Other great innovations that came out of the AO Foundation was a dynamic compression plate, which many of you familiar with orthopaedics would know. That was developed by Stephen Perrin and many others at the Research Institute in Davos. That same year as the DCP came out, VET became an important component to fracture repair. It wasn't just about treating human fractures. This happened because one of the founders' dog fell out a window and broke his leg, and he used the same principles to treat his own dog as he did people. And he recognized the importance of care of our patients, of our animal patients, in the overall scheme of things. And so I really admire this foundation for recognizing that and still acknowledging it. And so now what we see is the AO Foundation as a not-for-profit organisation works across several divisions here. Trauma, spine, CMF or craniomaxillofacial, vet, recon and sport. And so AO Vet is just a small part of this foundation which really aims to improve patient outcomes across species across the globe is really the mission. And so if you are interested in fracture repair, then certainly get involved and register with this organisation. And we had our second AO Vet course in Mumbai just earlier this year. The one before that was more than 10 years ago. It would be my great dream and passion to bring annual AO Vet courses to India, where I think there would be great interest. But I need your support to build community and to help me put forward India as a fantastic place to bring all of this the resources that come with this wonderful organisation. So again, it's a global network of more than 500,000 surgeons around the world. It focuses on education, research and innovation. This was from our Thailand course. And again, you'll see we had, in our 2 Thailand courses, I think 17 participants from India. So it was very fantastic to see. Okay, so we're now remaining time now. I wanted to talk about open fractures, how they differ. We talked about how we would approach a closed fracture. With an open fracture, the first thing I want to do is to put a sterile dressing on that, even before we stabilise the patient. Often the patient walks in the door, someone like Ellie is checking its heart and doing its vital parameters. I sneak in here and I place a sterile dressing on and I cover it over because I want to minimise contamination of that wound. Again, if they get infected, it's almost always bacteria from your hospital and not bacteria from the community. So cover those wounds up as soon as you get them. Stabilise your patient, provide analgesia, get your radiographs. And we also then can look at thoracic radiographs, AFAS, TFAS, whatever Ellie tells you to do to stabilise your patient. That's not my area of expertise. This is my area of expertise. And so, when I see an open fracture, I want to grade it because that determines how I can treat it. So a grade 1 open fracture is generally where a sharp piece of bone pokes out through the skin and then withdraws back in. The wound is small. It's less than 1 centimetre in size. And the really pleasing news is that if we see grade 1 open fractures, we can treat these like a closed fracture. There's no difference in infection rates. So this has revolutionised the way we treat open fractures because once upon a time we were told you could never place plates on an open fracture. Had to be external skeletal fixation. But what we now know, some studies out of Michigan State have told us that there's no difference between external fixation and internal fixation. In fact, internal fixation is likely to be favourable. And the reason for that is it's more stable and more durable because these fractures can take an extended period of time to heal. Grade 2 fractures are a little bit more like this. So now we've got a larger wound, greater than 1 centimetre. The configuration is still generally simple. There's still minimal tissue loss. The good news, grade 2 open fractures I will treat as a closed fracture in just the same way as a grade 1 open fracture. So, no difference here, except we have to recognise that there are longer healing times and additional fixation often required. So when I think about healing bones, and those of you who have heard me speak at AO courses will know that I often think of healing bones like baking a cake. When you bake a cake, you need the right ingredients, you need the right amount of ingredients, otherwise it doesn't turn out right. When you heal bones, you need the right ingredients and the right amount of the two. Now, really pleasingly, because most surgeons are very simple characters, when you heal bones, there are only 2 ingredients. There's biology, the blood supply, that's those cells, growth factors that we talked about, and then a mechanical environment. So we need the right mechanical and the biological environment. And so when we assess these fractures, open fractures instantly become poorer in biology. They're contaminated, the body has to get rid of all of that before it can lay down new tissue. So they take longer to heal, which means our fixation must be more robust and durable than the equivalent closed fracture. There's some controversy regarding removal of plates following an open fracture. So because they're in a contaminated environment, there's a higher risk of bacteria adhering to the plate surface in a biofilm. So there are some surgeons that will electively remove those plates. The biggest risk after plate removal, though, is refracture. And so there is somewhat of a controversial situation where there is no clear directive as to whether we remove those plates or we leave them in. We know that not all these plates go on to become infected, but we know that a small number do. And so we've got to make that decision. But I believe that as more research comes to light, we'll be able to answer this question more clearly for you. Now, grade 3 fractures are the most severe. This is where we may have vascular compromise, where we may have loss of tissue. This poor dog here, and I'll show you here, this is an example of a grade 3 open fracture. You can see there is a bit of bone sitting on the skin, that's never good, but we've got significant amounts of tissue loss, potential loss of viability. Now, being really realistic, unless I have an owner that is extremely dedicated, these cases in Australian dollars might be $30,000 as a minimum. It's probably going to require multiple surgeries, potentially reconstructive techniques, so flaps to cover them. So you need the right owners, and for that reason, many of these will result in amputation. If you have a grade 3 open fracture, I think it's very reasonable to discuss with the owners amputation, providing there are no other injuries. And that's what I did in this case. So in terms of what are the key take-home messages with open fractures, recognising it's open early is important. Cover it with a sterile dressing to prevent further contamination. I simply cover it. I don't clip or lavage it. I wait until I've given them analgesics, and then I clip, clean, radiograph, and stabilise with a bandage all in one go. And then when we talk about stabilisation, generally internal fixation for grade 1 and 2, external may be required in grade 3 with soft tissue repair. And don't forget, intravenous antibiotics are indicated. They're not prophylactic, they're indicated as a treatment modality. So this is a case I saw that came in the afternoon I was catching my flight here. So I was very excited because I had a case to present to you. I was a little stressed because my plane left in about 4 hours' time. So this is a dog called Goose, was hit by a car. We're putting in an IV here. We can see we've got a short oblique fracture, maybe mildly comminuted. It's open. You can see the wound there. So this is a grade 1 open fracture. It's a small wound. While we're clipping it, again, you'll notice all staff are wearing gloves, and we've covered that over sterile dressing and then a non-sterile covering afterwards. We hang the leg in theatre so that we're providing some traction. And you'll see this is probably a more robust repair than you would expect for a radius ulnar fracture. So the decision-making process here was to ensure that this may take 4 months to heal. The decision-making process was to ensure that we had adequate fixation in this. So we've used a 3.5 millimetre dorsal plate and a medial 2.4 millimetre plate here. So this is called orthogonal plate fixation. It's extremely robust and be very durable. The other option would have been to repair the ulnar, but you can see how close that is to the joint. This was difficult to get enough purchase in that small fragment. So in this case here, I actually left my, my fellow surgeon to close this. I operated with one of my other surgeons here, and I had to leave straight from theatre to the airport to come here, but he sent me these radiographs, and luckily we didn't have to go in and repair it, otherwise would have had to ask the pilot to make a U-turn. But case is going very well. This is him here, Goose, and this is him the day after surgery. So with rigid fixation, I would expect the animal using that leg very well even the day after surgery. So take-home messages. Most fractures occur after polytrauma. The importance of stabilizing your patient can't be overstated. Immediately cover that fracture with sterile dressings. Start intravenous antibiotics, and then we want to get to these cases as a surgical urgency, not emergency. I'll cut them as soon as the clinic opens the next day or as soon as reasonably possible. Okay. Well, that's all I have. Thank you very much. And we've got good time now for questions. So I'm going to open the floor. We've got 13 minutes for some questions now. So I need you to stand up for me. Yeah.
Thank you, sir, for a nice lecture. My question straightway is on the open wound healing. Is that when we are using the calcium alginate dressings, there is a common problem with the sticking nature of that bandage, so can't be applied on the big open wounds. So what precaution we can take if we have to use it? Then what precaution we can use to avoid that stickiness, whether any paraffin thing or anything which we can apply in order to avoid that?
Yeah, alginates are put on dry, but they become like a gel on the wound. So they will always, they're not a traditional wound dressing in the way we often think of it. You put it on and you take it off. So the only way to remove that is really to flush that off when you get that off. But again, it's maintaining moisture at the interface, which is a positive. So that's not normally a problem. You don't have to peel it off. You can just flush that out and then redress it on top. Yes, normal saline is fine.
Yeah, hi. We see a lot of trauma patients. There are a lot of times that we have seen that patient is clinically fine and after a few hours they just die. Yep. We do consider probably a thromboembolism. So I wanted to ask, how much do you consider thromboembolism and how do you consider in patients, and do you preemptively treat the patients with enoxaparin or something like that?
Yeah. Generally not. This is probably a better question for Ellie rather than myself. But generally I wouldn't recognise thromboembolism as being the major cause of death after major trauma. And I think Ellie gave a great lecture right at the beginning where she talked about the range of things that can result in death quite soon after presentation. Did you want to make a comment on that one?
In the acute trauma setting, we're actually more likely to use a drug like tranexamic acid to try and help form clots to prevent internal blood loss and bleeding. So in our hands, I'm not as worried about a PTE in a trauma patient than an IMHA patient who's a ticking time bomb for a PTE, and when they suddenly deteriorate with respiratory signs. Whereas if my trauma patient is suddenly developing respiratory signs, I'd be looking for, is there fluid or blood in the chest? Do they have a pneumothorax that's progressing? Because are these patients that you're worried about a PTE? What are their signs? What are their lung signs like? What are their breathing like?
So a lot of times we have seen that they are just doing fine, and if there is any mobility or we are transferring the patient or something like that, and all of a sudden there is a respiratory and cardiac arrest, and we are not able to revive them.
Yep.
That is when we think that it's probably a thromboembolism.
Yeah, look, I would be, now that we've talked a lot more about those perfusion parameters, I'd be watching these guys very, very closely, because that little bit of stress on an unstable patient tips them over the edge. But if we pick up a bit sooner that they're actually in hypovolemic shock because they're bleeding out internally that we haven't found yet, you may find that you could pick up on that before they're out, because sometimes they're okay, then they're not okay and they arrest very quickly. That's trauma. And we've got to find, is there a bleeding spleen or a lacerated liver from the abdominal trauma? Is there something happening in their chest? I'd go looking a bit more. Do you have ultrasound? Putting that ultrasound on frequently and looking for, because sometimes initially you can't obviously see a big pocket of blood. You resuscitate them a bit and you give them fluids and you go and look again, and there's 4 quadrants of, you can see fluid everywhere. I think sometimes just that first period, keep looking for what's wrong. Never say never about PTE, but generally they've got other underlying, if it was a Cushingoid patient who's got all the hallmarkers for throwing clots, it'd be on my list. But even in a trauma patient, a Cushingoid patient, a hyperadrenocorticism patient with trauma, I'd be worried that it's the trauma killing them, blood loss, pneumothorax, something else. Yeah. And I wouldn't, as I said, those patients, we're often actually giving them tranexamic acid to make them hold on to their clots and not break them down too quickly. A trauma patient, I wouldn't be anticoagulating. You're just waiting, there'll be a ticking time bomb to bleed, really. And the body is amazing at balancing coagulation, and sometimes we actually go in and try and mess with it too much if it's not indicated, and we create more harm than good. There is a very good open access, so it's free. There's a consensus now on the use of anticoagulant therapy in our veterinary patients. It's only been published in the last couple of years, and if you just type in consensus for anticoagulation, you'll get a very good guideline of when to use what and how and what combinations and dose rates and everything in there.
Yeah, how do you manage the traumatic wounds in the places like caudal aspect of the elbow in case of dogs, and also the caudal aspect of the hock in case of cats? Yes. Particularly, they are more prone for the pressure sores and all. Yeah, particularly the wound management aspect on those areas.
Great question. So skin will not grow over a mountaintop. So it wants to cut the shortest path. So if you've got an exposed bony prominence here and you've got skin around the base of that, don't expect it to go over the top. It just won't do that. So skin's much better at sort of filling in rather than going over the top. So the strategy we generally use there would be releasing incisions to try and close that wound once it's healthy. So you've got to address all those parameters that we spoke of. Get healthy granulation tissue bed. Do a delayed closure. And it's a bit like that hard palate, where we might make releasing incisions medially and laterally, close it quarterly over the incision, and it'll then treat 2 smaller open wounds that are not over a protuberance. So that's typically how I would address those.
Particularly in case of elbow, like caudal elbow wounds, do you like movement, like restriction movement and all? How do you restrict their movement?
Yeah, not really. And elbows in cats are a little bit interesting.
No, not in case of cats, in case of dogs.
Dogs, elbow?
Yeah.
You can, yes, you can try the releasing incisions, yes, and you can try and immobilize them. If they're significant in their size, generally a thoracodorsal axiopattern flap. But these are potentially prone to maybe make things worse, because if it fails, the risk is that then you've got donor site morbidity and still an open wound. And so these can be very challenging. So I generally go for the simplest technique to solve the problem, because the more complex we get, the more risk of harm. But in my hands, generally an axial pattern skin flap.
Okay, thank you.
For your big wounds, what would your pain management be, and for how long?
Yeah, so pain management for big wounds. Generally, it's not that long, because once you've got granulation tissue bed there, that's not painful. Got no nerves in it. The nerves take 3 weeks to come into granulation tissue. So actually, the pain is generally just for that immediate inflammation. Because remember those inflammatory mediators that sensitize for pain, yeah, they're only there for a relatively short period of time. So we're probably talking about 5 to 7 days of pain relief. Non-steroidals would be appropriate, providing there's no other contraindication. But you don't have to provide them analgesia the whole time that wound is open, because generally they're not that painful once you get through that initial inflammatory period.
Hello, Doc. Use of stem cell therapy.
Stem cell therapy, okay.
In fracture management.
Okay, stem cells in fracture management. So fractures are no different from other wounds. So there is something called the diamond concept in orthopedics that say mechanics sits at one corner of the diamond. At the other corners are cells, scaffold, and growth factors. And this is important when we provide things like bone graft. We say, what are we bringing in? If you bring in just cells without growth factors and a scaffold, they won't do anything. And so there's a lot of work in human research to build biological scaffolds to put the stem cells on. Generally, though, there are alternatives. And so you've probably got the gist that I'm not into purchasing a lot of new products, but using the body's own tissues. So if I want to stimulate healing further, I'll use autogenous cancellous bone graft, because that has not just osteogenic cells like the stem cells, it's also got structure, the honeycomb cancellous bone, and it's also got growth factors as well, all the bone morphogenic proteins. And so typically, if I want to stimulate healing, you can find it within the body itself. You don't have to reach for a whole lot of product or to purchase either allogenic stem cells or to produce them from that own patient. The gold standard in stimulating bone healing, autogenous cancellous bone graft. You can purchase components of that, recombinant human BMP2, for instance, but often they're not required. Autogenous cancellous graft contains all the elements. Stem cells is just one of them. So